but over history, our DNA does have evidence of bits of virus being incorporated into it.
Oh, lots of it. Some people say sort of 8-9% of the human genome was originally viral.
And that's normally viruses that most of that is viruses that are DNA viruses and that have the apparatus to get themselves into cellular DNA in order to be replicated. But it's not all DNA viruses, and there are ways in which RNA viruses can end up as DNA in DNA. And just, we've talked a lot about the mRNA vaccines. I think it's worth touching also on the DNA ones. So AstraZeneca and Johnson & Johnson used a viral delivery system to get DNA into the cell. And so they were targeting the nucleus. The virus itself was targeting particular organs. It wasn't every organ, but it was quite a range of organs. The gut and the liver and can't remember all of them. And the material went into the nucleus, but it was in the nucleus without being in the chromosomes. Like, that's what that virus does. It creates a sort of piggyback little mini nucleus within a nucleus. So in theory, that wasn't going directly into people's DNA. It was just being used within their cell nuclei. And again, if the cell's destroyed, it doesn't really matter either way. It's only when the cell isn't destroyed that you might get a problem.
Yeah. So if there's DNA contamination, whether it's from one of these adenovirus vector vaccines or whether it's some DNA contamination in an mRNA vaccine, that DNA can potentially get into the chromosomal DNA, potentially. Does it need reverse transcriptase to do that, or can it just sort of diffuse in? I've never quite understood that.
Yeah, it needs to be made into DNA in order to do that.
So it needs reverse transcriptase.
Yeah, but the thing is that there are those types of enzymes around on occasion. It's not something we're completely immune from happening.
No.
It can happen at a low level, and I think people have shown it has happened now. They've shown in cancer cases.
Yeah.
That it was in the DNA in some cases.
Yeah.
I don't think people should panic that that's happened to them. I think that's always this interesting kind of psychology around all of this, is that people don't like to hear about harm because they took it.
Yeah.
And I just like to kind of emphasize that the harm is in a minority of people. And you, by sticking your fingers in your ears to what the harm might be, you're sort of prioritising your ego over helping address the harm that a minority of people have been affected by.
I agree, but I'm pretty angry that I've been conned into a game of Russian roulette that I didn't understand. So this picture here, Claire, this could be a physiological situation, isn't it? Could we, with the enzyme reading the DNA, making the RNA?
Yeah, that looks healthy.
Yeah. Yeah.
But we don't know what that DNA sequence was. I guess that's the point.
Yeah, I think so, yeah.
And the other thing, of course, is that we don't know what was happening with the bacteria in the gut. So there's quite good evidence that there was a problem with virus in the gut, in an infection.
Yeah.
And that some people end up with virus in the gut longer term in kind of long COVID cases. So the bacteria seem to play a role in all of this. And I think that might prove to be the case in vaccine exposure as well. Because bacteria love taking up DNA and seeing what they can do with it. It's like, they take up plasmids, it's their thing. And, if it kills them, it kills them, but they're just constantly reproducing, so you've always got evolutionary drive. So I do think the gut may play a role, and that might also explain what I've kept referring back to about it shouldn't matter if the cells are dead, because if it's in the bacteria, then your immune system is living alongside those gut bacteria. It's not going to be attacking them in the same way.
Yeah. So here we see the spike protein on the surface of the viral particles. So this is a spike protein on the surface of the SARS coronavirus 2.
So the way that ends up there is that the virus has got a lot of instructions. I mean, not a huge amount, but more than just spike. And those instructions hijack other parts of the cell machinery, so that when it's replicated its whole RNA sequence, make a new virus, that gets carried to the surface to the membrane of the cell.
No, but this is the actual viruses we're seeing. In
I know, but the membrane has already got spike on it.
Oh yes.
So as it gets extruded from the cell, the spike on the cell membrane encapsulates it and it's off.
Oh, I
so
see.
like part of the viral replication works by getting the spike onto the cell membrane. That's how the virus is going to use it. So, I don't know what that means in terms of when it's not got all of those different instructions around, but the idea that your spike would be on the cell surface might be integral to what kind of a protein the spike is, how the cell deals with that kind of a protein, is to stick it on a cell surface. Yeah, and of course, it did circulate in the blood. But our immune systems are brilliant at dealing with foreign material.
Yeah.
So it was quickly removed from the blood. It wasn't like it's circulating for a long, long time. But in the immediate aftermath of an injection, you've got some in the blood, and then your antibodies would just be hoovering it all up.
Yep.
I mean, one of the things that bothers me about, I was saying about how the immune flags were bypassed, the things that say to the immune system, I'm being hijacked by a virus, weren't there. And one of the parts of the spike causes lymphocytes to hold off their immune response. There's a thing called PDL1, which it allows the sort of cell to kind of escape immune responses. And that happened with the virus, absolutely happened with the virus. And that's the reason why in an infection, compared to other viruses, although actually other viruses use all sorts of techniques like this to hide as well, but it was taking a bit longer to get the T cell response to trigger. So the T cells were starting to learn what they were aiming for, but they weren't being told to fire. And so that meant there was more infection of more cells at the point where the immune system says fire. And so in some people, that delay meant that there was a lot of cell death all at once, and then you get the sort of cytokine storm reaction, you get the sort of toxic drops because you're killing a lot of lung cells all at the same time. So it was all about that immune delay. But that same bit that sort of downregulates PDL1 is in the vaccine spike sequence as well. And so, you're meant to be telling the immune system, come get me. I'm a vaccine infected cell. I want you to learn how to kill me. Come and get me. But it was included that part that says you can ignore me, which is also the same sort of signalling that cancers use to evade the immune system. So in many ways, the way these cells were evading immunity was similar, because it was, it didn't look like it was infected by something foreign. It just had a weird protein that seemed to have come out of it from it inside in a way that the immune system wouldn't understand as being foreign necessarily. At the same time as saying, you can ignore me. And
I particularly love this one, Claire, where we've got a cell where the RNA has got into, and this spike protein is just produced on the surface of the body's own cell. So we now have the body's own cell.
And of course, there are some cells you do not want to mark for destruction. If it's a respiratory epithelial cell, those cells are designed to have a short life expectancy because they will be infected, our bodies will kill them, and they will be replaced. And so there is a turnover. Same with our skin surface cells, they get shed. So they've got a role in being something that dies a lot. But there are other cells in our bodies, like our brains and our hearts, that cannot be replaced at all. And so you don't want to lose any one of those cells, because that's it. And in the brain, obviously, we want our brains intact, thanks very much.
Yep.
And in the heart, when you've lost a heart cell, it gets replaced by scar tissue. And the heart is a very delicate electrical organ, so you don't want scar tissue in it, which can cause short-circuiting.
Yeah, and potentially lead to abnormal heart rhythms, as well as loss of the muscle. So you have the mechanical deficit, which of course can lead to heart failure if it's bad enough.
Yes, and we know those things have both happened. On a population level, there was a rise in cardiac arrhythmias, particularly AF, but all sorts of arrhythmias.
Yeah.
There's a rise in sudden cardiac death. There was a rise in heart failures.
Yeah. So here we've got the body cells expressing foreign spike protein. So this could be the endothelium here, the lining of the blood vessel. And instead of being nice and smooth, it's now all rough because it's expressing spike protein. And those spike proteins are saying to the immune system, better kill me, I'm infected with viruses.
That's right. And that whole, you can see there they've got an area that's so infected that you're going to have a wound when all those cells are killed off.
Yep.
Which would be a clotting risk.
Yep.
Yeah. And in the infection, when you have an infection, the virus is pretty confined to the respiratory epithelial cells. So there isn't evidence of whole virus in the blood. There's evidence of RNA in the blood, but that's debris from killing them off. You know, that doesn't show that you've got whole virus. No one's ever shown whole virus in the blood. There was evidence of circulating spike proteins in the blood, which again is a kind of debris, you know. So, you know, I do think there were systemic effects from circulating spike proteins, but they'd get shut down quite quickly by the immune system. And so you can compare how much circulating spike there is from a viral infection to the vaccine circulating spike. And it's, you know, it's quite a frightening sum. I can't remember the exact number, but it's comparable. You're not, you know, the idea of a vaccine in theory is it's something inert, it's something tiny, it's just a little instruction, it's a little education, but the volume here is out of proportion to that.
Yeah. Interesting. So normally when you have a respiratory virus, you don't have a viremia, you just have viral fragments, and that's what gives rise to the fever and all the other systemic response effects. Yeah,
so there's a nice quote that I wish I had at my fingertips from a paper that Anthony Fauci co-authored around how there wasn't a viremia. The mRNA in the blood should not be considered to be a viremia. It is just debris.
Yeah. And what we're seeing here is these cells are actually being destroyed by the immune system, presumably mostly by cytotoxic T cells, I would have thought, Claire.
Yeah, so there's two types of T cells. There's the ones that destroy cells that are virally infected, and there's the ones that are sort of the generals who are making the whole immune system be coordinated and have the memory of what's gone on.
Yeah. Are the antibodies acting as what's called opsonins, Claire? Are they like labelling?
So they'll be labelling the free spike in the blood.
Yeah.
And then, yes, they when they're bound to spike on a cell, it is enough itself to generate a cascade of chemical reactions that lead to like the insertion of kind of channels in the cell membrane that cause the cell to just be drowned and destroyed. And then they're also saying to the other cells of the immune system, this is a bad one.
Yeah, they're called perforins, aren't they? They actually perforate the cell and result in the death of the cell. So what we're seeing here basically is lots of cells in that particular tissue there have been destroyed. So that actually constitutes a wound, and that's going to be a site for, not only is this endothelium not producing its anticoagulants, it's actually going to be a pathological site which can trigger the coagulation cascade. And I think as well as that, another thrombogenic mechanism is the spike protein itself has been found inside the blood clots.
That's right. They could show that if you took blood and added synthetic spike that had been made, using that vaccine sequence to it, that created this weird kind of clot. I'm not sure we should call them clots because they didn't have, platelets weren't needed for it to happen. Normally platelets are really important in clot formation. But this just required the fibrin, which forms a kind of structure of a clot, and the spike itself. And there's these beautiful images that have been done on electron microscopy of what a natural clot looks like and what these clots look like. And the fibrin looks like spaghetti. And then you've got this parmesan all over it, which is the spike proteins that are causing it to stick together.
All right, so the spike proteins causing the fibrinogen to come out of solution, essentially, directly.
Yeah, directly. And of course, the thing is that, as well as having very delicate mechanisms for clot formation, we also have delicate mechanisms for clot destruction, because removing clots is a key part of keeping everything functioning well. And this is a foreign thing. The spike fibrin bound inverted commas clot is not something that those systems could remove in the same way.
We have these mechanisms. Tissue plasminogen activator was the drug that we used to activate the plasminogen in the tissues, which actually breaks down the clots. And so really we've got three mechanisms of thrombosis here. We've got the reduced natural anticoagulants that aren't being produced by the damaged membrane because the membrane is partly dead. It's not producing what it normally produces. We've got the physical wound effect, which is going to attract, potentially stimulate platelet activation. And we've got the actual direct thrombogenic effect of the spike protein itself. So we've got three mechanisms of thrombosis there. Yeah.
And of course, with we said we've got a clotting risk, right?
Yeah.
So if we had this in theory and said, well, what would you expect if you then injected a population? I think you and I would say you would expect strokes, pulmonary embolisms, heart attacks, and
DVTs,
plus more, right? And the evidence is that there was a bit of a signal on those things. What's difficult is those things are very common. So you can increase how many there are in a year, but to show a statistically significant increase takes a lot of disease, unless you're looking in populations that don't normally have those problems. So if you can focus on a young population and say, well, they don't normally have, strokes. How many strokes in young people were there? Then you start to get a better understanding of the risk. But that doesn't mean the risk wasn't there for the older people. It's just that the signal statistically isn't there because there's more background. But I think what was happening was a lot of this clotting was happening in very, very small vessels because of that thing around stagnation of the flow to get into a large number of endothelial cells all together, all in one place. And so it's the smaller vessels damage that leads to damage in all of the organs, because that creates an area of damage within whichever organ that little vessel is in. And so then you get a situation where there are people who, prior to all the vaccines, let's say they had a problem in their kidneys, and this problem in their kidneys they were completely oblivious to, and they may have lived the rest of their life without ever knowing. But then they killed off a load of healthy kidney cells, and then that kind of exposed a problem that they might not otherwise have had. So there's that problem of sort of cellular reserve, that you don't want to go destroying healthy cells because they might be compensating for problems that you didn't know about. And so I think that is really important to understand, because if you understand that you've got problems in vessels, that could be in every organ, and that if you've got this problem with cell reserve, that you're killing off cells that are expressing spike, that can be in every organ. And so you start to see a pattern of lots and lots of different diseases apparently being caused by the vaccine. And our safety mechanisms are set up to say, we want to understand when there's a signal that's genuine, and when there's a signal from increased reporting.
Yeah.
So they say, well, if you've got things in all sorts of different organ systems, we'll ignore it because that's just a reporting signal.
Yeah.
But in actual fact, the MHRA in the UK, they published that the sort of yellow card reports for all the other drugs. So they were claiming there was an increased reporting signal because they'd done such a good job at selling yellow card reporting around the vaccine, which is obviously something they ought to have been doing. But they didn't do a good job of it because reporting for all the other drugs actually fell in that period. So, there was no increased reporting. It was the same doctors who were continuing to say there's a little problem with the drugs over here, and they were saying there's a big problem with this drug, but it's a problem that's affecting lots of organs. And when people managed to get hold of the data finally from America, they could analyse different the sort of reporting rate for different conditions. So I'm not saying there was no coincidental reporting. There's bound to have been some, but you can use the sort of level of coincidental, very low level reporting on some organs to say, well, how much more often were things like myocarditis being reported?
Yeah.
And you get that sort of ratio between the two. And when you do that, there were 770 different conditions that had a higher signal than myocarditis.
Wow. Incredible. And as well as that, the signal should have been lower because a lot of old people had died, and the old people would normally suffer from more of these pathologies.
Well, no, but to be honest, I think if you're an old person and you've got a vaccine injury, trying to persuade a doctor of that is really, really hard.
Yeah,
really.
But I mean, a lot of old people died from things like midazolam and morphine, and
yeah, that too. Yeah. But I think what was happening with the reporting is people saying, "Oh well, of course there's lots of deaths and disease because we've injected lots of old people, so of course there are." But if you dig into the data, the reports are not disproportionately in old people at all.
Yeah.
The reports are in middle-aged people who shouldn't be having these conditions, because then it's much more obvious to a doctor that something's wrong.
Yeah. And the other thing is that if you kill off a portion of cells in an organ, then you might not notice that when you're 25. Because it's like renal function. When you're 20, you might have, 2 times more renal function than you need. When you get to my age, you've probably got exactly the amount of renal function you need. But in 10 years' time, I might have a bit less renal function than I would like.
Yeah.
And if you've already killed off some cells, you lose that reserve. So we could actually, over the coming decades, get what are essentially accelerated aging effects.
Yeah, we might well do, because of course aging ultimately is just organ decrease, isn't it?
Yeah, and aging is just basically due to the fact that your stem cells have only got so many divisions, and once they're used up, that's it. And if you've destroyed it's a bit like Parkinson's disease. The idea that someone's exposed to an environmental toxin, it takes away their reserve. You don't notice it when you're young, but decades later, when you get normal cell senescence and death as well, you haven't got the reserve because they've already been bumped off when you were young. So you develop the symptomatic disease. It's
yeah. No, I am concerned about that. So I think to say something that's slightly a counter to what a lot of other people have said recently, in terms of excess mortality, I think we saw a wave of vaccine-related excess mortality, particularly in 21 and 22, with a bit in 23, and by the time we get to 2024, it's over, actually. And I say that because I managed to find an ONS population prediction for deaths. So they have to say, well, looking to the future for planning how many deaths are we going to see every year. Yeah. And this was done in 2018. So this population prediction for deaths, I think, is a fair way of saying how much aging is going to contribute to mortality over the time. And by 2024, we were back to roughly where we should be as a population as a whole. We weren't for younger people. There are still problems, but the bulk of that death wave as a population was over. So I think that we saw this kind of medium-term problem, but we're now in the long tail, and we don't know what that's going to include. Because it becomes harder and harder to measure it and to attribute it to something that happened years before.
Correct.
But I think there will be a long tail because of the nature of these products. Oh, there's a clot.
Yeah, that's a blood clot.
We've done it with, yeah. I mean, in actual fact, there weren't many red blood cells in these weird clots. That's why there's that sort of white clot.
So the white fibrin platelet-rich clots. But they'll still block off the blood supply.
Yeah.
Yeah, so thanks very much to Archie for allowing us to use those quite incredible graphics. Yeah. Brilliant, Claire, thank you.
That's right. Did you want to talk about that last image?
Oh, this one?
Yeah.
Yeah, go for it, yeah.
So, well, John said he'd done this to get them to scale, so you could see that the virus, which is really one of the tiniest things, it's hard to kind of describe quite how small viruses are, but the lipid nanoparticles are another degree smaller than them.
Yeah. And can squeeze through little spaces that aren't supposed to be squeezed through. Yeah. So thank you so much for that, Claire. And I believe you're working on something quite interesting now. Are you working on something quite interesting now?
I am. I have been very, very occupied and busy over the last few weeks working on the autism story, which is something that, I got captivated by, frankly. It's sort of drawn me in, and there's an awful lot about it that I think we can understand much, much better than we have done so far.
And I understand you've got a video and some publications coming up, hopefully in the next week or two.
That's the plan. So the plan is to have a publication that can get peer reviewed, and then a video to explain it to everybody, and then launch it.
Well, there's only you and me listening, Claire, so you can tell us what it's about now if you like. There might be a few eavesdroppers, but I doubt it.
What I will say is that Dr. Tim Kelly is the one that got me onto this. He had this brilliant idea, and we've been working on it together. And it ends up being a sort of framework for understanding all the risk factors and how they fit together. And it has really big implications, which is why we're doing it slowly and carefully, and not just doing it bit by bit as we go along.
Excellent. We'll be waiting. So when will we hopefully get a release on that?
I'm hoping in the next few days.
Wow, fantastic. Yeah. And if you would choose to come back on and talk about it, we will, of course, be delighted. Thank you for that.
Love to. Yeah, thanks, Tom.
Look forward to that. It's always good to leave on a cliff edge.
Yeah.
Thank you.
Thanks, Tom.